Welcome back. Greetings to all the OrthoTV viewers, and we carry on the part 2 of coding of the upper quadrant pain. And we have with us Dr. Tejashree Dabholkar, whom we had introduced last time. And ma'am is a master's and a PhD as well as a Heimer fellow. And she has worked extensively in hand rehabilitation and assessment and pain. So, ma'am is going to share her inputs, and we are going to continue from where we left the lecture last time, and we will be starting the part 2 today. So, welcome, Dr. Tejashree Dabholkar, ma'am, and I
Thank you.
hand over the session to you.
Thank you, madam. So we will begin with the part 2. Now, in rheumatoid arthritis, we say RA is due to the inflammation. But peripheral sensitization is widely held to be responsible for pain tenderness. We accept that. But it does not account for other symptoms observed in RA and for enhanced responses. So this particular article is very important because they're saying that in RA patient, there is a possibility long-lasting central sensitization or increased activity of the sympathetic nervous system. So why RA patients later on start showing other signs and symptoms? We say it is a plain inflammation. So why the input comes from non-inflamed regions also? The area where the inflammation is not set, still the pain has been seen. So there is a central sensitization which is seen in a rheumatoid arthritis cases. So beyond our the basic management, we have to consider this factor also. Now this particular RA patient, see the function was improved much better in our patient. But I highlighted because this patient gave me a tough time because this patient was having various other autonomic disturbances, and there was a lot of query between us whether it is only RA or it is a RA along with CRPS. So we were thinking that RA patient has developed now CRPS like things, and then both the things we have to tackle. But when this particular article we read, then we thought maybe possibly it is the symptoms were so much overlapping that segregating it only as a RA and now developing into CRPS was difficult. But when we see such article, yes, RA patients are having central sensitization, and that was giving a tough time for the patient to come out of the pain factor. So we had to use a lot of other techniques to divert our pain from a lot of issues. The CRPS case has given us a lot of improvement, but there was a lot of time on the pain factor. So mobility was better. The ranges, it was just a distal end radius fracture. But the past experience of the patient, I can say the past experience with the healthcare system, which she had, her encounter with the few of the places where she was not given a right advice. So when she came to us, she was in a denial phase. And in that case, we consider it as a plain distal in radius ulna, but uh, later on, she turned out to be a CRPS case, and managing her was a difficult task because those past experiences and the histories which she was having, a whole baggage of the visits to various hospitals and various therapists made her difficult to come out of her pain. So a lot of time was given to patients. So every patient may not need our time. We have to find out that which patient needs some more time, and along with the basic electrotherapeutic and physiotherapeutic skills, the additional time about tackling and managing their pain has to be given. When the patient with the multiple fractures and tendon injuries comes, it again become difficult. So these two cases gave us a time because uh, mobility improved, functions improved, but the patient of the tendon injury was having tremendous pain. And when the tendon continuity was still there, still patient was reporting that there is something which is breaking inside. And so it was making patient understand that your pathology is now getting corrected, the recovery is happening, you are on a right track. Still the tough time was given by these few cases. So there always remains in a brain that how they have taken more than a year to come out of it. So in all these cases, pain assessment is very essential, we can say, because by knowing all this theoretical background, when we assess patient rightly, we know which patient to spend more time. So location, intensity, duration, quality is definitely important. Intensity experienced by patient is individual, that we have to know, and it is most difficult to assess, though we have all the objective measures available. Duration we have to consider, and very important to go ahead with finding out whether it is a nociceptive pain, neuropathic pain, or neuroplastic pain. So knowing in your history, trying to find out these things are very important, and categorizing them into those first three categories, which we have just discussed, is very, very essential, because that gives us a guideline that if it is a neuropathic pain, nociceptive pain, what will work better in that particular patient. So this kind of the pain assessment about pain inhibition, about enhanced central excitability, we have to discuss out with the patient. There are a lot of scales available, pain catastrophizing, pain direct questionnaires, which help us to go ahead and find out about these areas in much detail. Now, how we can deal with this? There is a behavioral approach which was always into our text, which is, we know everybody about the operant conditioning. Okay, it can be positive or negative. It is, but it is a first way of behavioral therapy. Then came about cognitive approach, which was the second wave. And then came, very important, is cognitive behavioral therapy. So this particular thing, so we are not going into the depth like a psychologist or a psychiatrist. But as a physio, when we are dealing, we need to know these aspects. And somewhere we have to go ahead and use this techniques. So cognitive behavioral therapy suggests that coping skill like relaxation or activity management, specific exercises are very important, and they are developing a good coping ability in a person to manage their own pain. Now, WHO after that now have moved ahead and added uh, the psychosocial factor. And one more very important is a spiritual model. Now, there's a biopsychosocial spiritual model. So pain is considered as the entity where the other factors are also considered, and the spiritual model has been added to it. So addressing a patient suffering from chronic pain using biopsychosocial approach provides physician with the knowledge that is necessary to treat all the factors. There are multiple research which has shown that biopsychosocial approach to the pain allow for greater restoration of upper quadrant functionality. So we have to consider all this. Now, how we can go ahead? First is a patient education. We say that we should educate the patient about the pain, educating about their pathology, their recovery, their rehabilitation process is very important. Along with that, very important to educate them about the pain mechanisms. We have to tell them about how the pain has been processed. Maybe that first diagram where the input processing and the output which was used, you can show that to your patient and explain that in this process of rehabilitation, they will be perceiving pain, the nociception, which will be processed, and then the pain as outcome will come. But which mechanism works around it? What are the challenges? How you can control your pain? What is pain appraisal? Or what is some pain catastrophizing? So explaining or educating them about the mechanism of the pain is very, very important. Explain them that what it is exactly. What is the meaning of central inhibition? This education may be useful for those with the maladaptive cognition, behaviors associated with altered CNS processing, but making them understand in a simple language which they understand is very important, in their layman's language, you have to go ahead and explain them what happens. Apart from these things, the other mechanisms, other things which can help is whenever there's a central mechanism involved. Always we say regular exercises are very important because it reduces central excitability, expression of excitatory neurotransmitters, increases the release of neurotransmitters, reduces glial cell activation, or increase all anti-inflammatory cytokines, decrease inflammatory cytokines in the spinal cord. So ideal choice for those with the nociplastic pain, where we say that there is more excitability and less of the inhibition. So why do we prescribe aerobic exercises or a regular exercise? So very essential. Upper quadrant pain, even though pain is there, a certain exercises should be done. Why they should be done is because of this reason. They are related to release of so many pain controlling structures. So regular exercises become a part in a central mechanism. In nociceptive mechanism, where the nociceptors are actually sending the impulses, exercises reduce the nociceptor activity by decreasing the ion channel expression, increases the expression of endogenous analgesic substances. They restore normal movement of the joint and tissue, which could hypothetically remove a mechanical irritant to the nociceptor. Thus, exercises decrease nociceptor excitability, increases peripheral inhibition, and promote healing of injured tissue. So whenever we give exercises to the peripheral structures, all these are going to help. Manual therapy works better whenever the central mechanism is there. So massage or joint manipulation, they modulate central pain mechanism. They activate descending inhibitory pathways. Joint mobilization uses serotonin, noradrenaline, adenosine. So these receptors which are there in the spinal cord, which are related to the analgesia, they are basically released. And that is how manual therapy activates central inhibitory mechanism and reduces central excitability. So whenever neuroplastic pain is there, manual therapy does help in that case. So nociceptive mechanism is also working for the manual therapy, and neuroplastic is also helping, because in nociceptive, what happens when we are giving manual therapy, all of us knows that there are receptors which are getting activated, and that is why how the inhibition of the pain is there. So there's a peripheral inhibition which has been seen, and the soft tissues are getting healed. So the receptors irritation is also minimized. So manual therapy in case of nociceptive and in case of neuroplastic pain is very essential. Electrotherapeutic modalities for the upper quadrant has a better benefit for the better performance. It was seen that specifically in upper quadrant, there are few of the literatures available on low-level laser, ultrasound, and thermotherapy or electrical stimulation, which are used for the upper quadrant, have given a better results. Specifically in a rheumatoid arthritis, this has helped for reducing central excitability and improving the peripheral inhibition part. So TENS is very effective in a nociceptive kind of the pain. In a central mechanism also, TENS works through the central mechanism by increasing central inhibition, reducing central excitability. So it works on a central mechanism very essentially. Ultrasound is also having the effect. Whether you take a pulse or a continuous ultrasound, it reduces the nerve conduction velocity of the pain nerve fibers. It has been seen to suppress the amount of the pain. And very important in the RA patients of upper quadrant is to respect the pain or follow this joint protection principle. Because if we are stopping the activity by respecting the pain before the pain is elicited, then the vicious cycle will not continue. Or we teach them to balance their activity and rest before they are getting tired or they are actually beginning with the pain, then they will not enter into that vicious cycle. Then all that concern about increased central excitability and reduced peripheral inhibition will not happen. Because in a long-term case of RA, somewhere the central processing get affected and autonomic nervous system get involved. So in the beginning stages, when we are dealing with the RA patient, when the joint protection principles are used efficiently or they are educated about it, definitely the inflammation will be less, but along with that, the central mechanism will not start that vicious cycle of pain again in our patient. Neuropathic mechanisms, in this case, regular aerobic exercises does help, manual therapy does help. Psychosocial mechanisms of the pain when they're involved, the first important thing is about the education, about cognitive behavioral therapy techniques, changing beliefs, pain catastrophizing, fear avoidance model. Explaining them and taking a time to correct these things is much more easier. Exercises will definitely have the reduction or the improvement on the cognitive function. Massage, so in a psychosocial mechanism, these three things does help. So in a broader term, if we want to summarize, when it is a nociceptive pain, exercise, massage or tense does help. When it is a nociplastic pain, patient education, because we know central excitability is high, exercises, massage, manipulation, and a modality. Though over here TENS is mentioned, there are other modalities also which can be used. Neuropathic pain, when it is there, many of the time in a neuropathic pain, exercises become must priority. When it is psychosocial pain, patient education, exercises, and massage does help. When it is a motor pain, it is education, exercise, and manipulation does help. Below is the line which is given about various kind of the pharmacological agent which helps in individual type. Very important to know that in case of the nociceptive pain, there are certain antidepressants which are given. Our patient may need such things. So referring our patient by identifying a type of the pain to the right experts is very important. If I get a case of CRPS and if I am not referring the patient for the medical management, then it would not be appropriate because patient needs the medicines also. They need something which can work at a cellular level, and we are also working at the tissue level. But knowing this in nociceptive pain, what type of the medicines are involved, in nociplastic pain, what type of the medicines are involved, in psychosocial, they need to be on some of the antidepressants. In motor pain, it is much of the muscle relaxant. So having this particular pharmacological knowledge is much more important because then we can send our patient to appropriate specialists so that they can get uh, a right kind of the multidisciplinary approach. And that's why right now the concept of pain clinics is coming up, where under one roof a physiotherapist along with the pain specialist is also there, and psychologist is there, psychiatrist is there, so that dealing with these multiple things become much more easier under one roof. So now the new concept of having a various pain clinics is coming up, and physiotherapist is much more essential part of this particular pain clinic. But if we know all segregations, or we know how to have the mechanism based approach to the pain management, then dealing with the pain become easier, and reference, a right reference is much more easier for us. And that's how our patient will be benefited. So decoding pain is a time consuming thing. But if we deal with more patients in this particular way, it will be easier to identify them in a shorter time also. and give them maximum benefit. Because ultimately, what is important in a long-term chronic cases of upper extremity is a patient satisfaction. And if these all approaches are used, definitely patient satisfaction would be the maximum thing which you will obtain. So with this, I would say that there are some take-home messages that learn to give a pain diary to your patient. Ask them with the structured questions to write down about their pain. Pain reflection. This pain reflection is by patient. What they feel about their pain. What is their impression about the pain? What they think that they can control their own pain? Do they think that this pain will definitely go and they will be pain free? Certain simple questions which will be a reflection. Identification of patient pain behavior as soon as they come in your OPD. May not be in a first visit, but definitely upper quadrant patient, they come for a long time, and we know that minimum 5 settings are required for these patients. So identification becomes much easier. Using biopsychosocial spiritual model for that matter, using appropriate electrotherapeutic and physiotherapeutic skills. And very important is respecting pain as a multidimensional entity and not labeling your patient as a psychiatric patient who doesn't know exactly how to report a pain. Patient really doesn't know how to report it because it is a complex phenomena for them. And we have to respect pain as a very important multidimensional entity. So I would say with this particular decoding, it would be, I would recommend that next time spend more time on evaluation of the pain. Thank you.
So thank you so much, ma'am. I guess everyone who has been hearing this talk, I'm sure they have a lot of take-home messages, not only the ones which are listed down there. And I guess we have got a better understanding about how we have to code the pain. I'm sure.
Yes.
So at least if you kind of try the broad categories of the nociceptive and the noxiplastic or the neuropathic pain, but apart from that, instead of compartmentalizing them into only these three, I'm sure, as Tejashree ma'am also pointed out, you have patients who are in between also. I mean, ma'am
Yes.
did mention how CRPS falls into the noxiplastic and the neuropathic. Similarly, ma'am, I'm sure you must have, I mean, what is your experience about hand injuries? For example, when I treat OA knees, I kind of see them falling into the bracket of both noxiceptive as well as noxiplastic range, categories, sorry. So what is your experience been about treating hand injuries and pain in the upper extremity? Because especially as you pointed out, the lower end radius fractures are, I mean, we feel it's only lower end radius, and then we see these patients who are taking forever to get better, and I guess we
Yes.
have to change our approach towards them. Yeah, but I'd like to know your take on it.
So basically for upper quadrant, it has been always seen that if I take a case of the industrial hand injury or multiple trauma cases or a crush injury cases, the incidence itself is so traumatic to the patient that the past experience and the encounter with the healthcare professionals is influencing patients' behavior as soon as they reach to our OPD. And further from that, when we go ahead with our managements, then it becomes difficult because we have all the modalities in a place, but still managing their pain becomes difficult. So functionally, they improve over a period of time of 3 weeks or 4 weeks as per the tissue healing phases which are going on. But this particular factor always remains. And for that, they keep on visiting our OPDs. And that time when we know that the tissue is healed, still why do they report to us again and again? So there's somewhere we have left certain things in the beginning not touched upon certain areas which we should have tackled in first 4 weeks of hand injuries, which are much more essential for rehabilitation. So first 4 week of any hand injury, any upper quadrant injury, if we are giving much priority to these things, then the rehab goes ahead much easily with us.
Okay, agree. So basically, ma'am, what is your experience in shoulder pain? Now, you did mention the various, I mean, we know that in the hand, there's a predisposition to developing CRPS. We know that when there are multiple injuries, multiple tissues are, healing at different time frames. And of course, the assessment of the pain, which we may have left out in the beginning, may result in a little mismatch between what we are expecting a prognosis and what really is happening with the patient. But what is your experience with shoulder pains? Now, we experience, recently it's been, I guess, post-COVID, I would say, the amount of shoulder patients that we are experiencing,
Increasing,
shoulder pain.
yes.
Yeah, it's been really, I mean, there are patients who come to us and we are unable to kind of, again, match between the nociception part and the noxiplastic part, because we do feel that from the actual injury or the trauma point of view, it's not really that much. And even if we do consider the impingement and other causes where the force couples are not working, there is a aspect of pain that I guess we need to kind of extend our thoughts or our perspective into. So what is your take on that?
Yeah, specifically, ma'am, I've seen in case of the impingement patients and those with the pathomechanical variations. So
Hmm.
do we, even though we are working on those areas, still the pain was not getting, not subsiding so easily. So post-COVID, it was seen that there's something, the central, maybe we can say the central processing is getting affected in them. Maybe a lot of psychosocial aspects are involved into it. And they were not reporting to us on time also in this particular time. And as soon as the COVID got over, all of them started reporting. And by that time, a lot of patients were into a chronic phase also. So a lot of shoulder patients are having this particular increased central excitability and less of the peripheral inhibition, which has been seen, though actual tissue involvement was not so much.
So you also have encountered these
Yes, yes.
patients.
Specifically, impingement problem patients, I've seen that
Yeah.
it was much difficult to manage their pain.
Hmm. Exactly, exactly. So that's what I was just, because we are decoding pain in the upper quadrant. So I thought I might as well push in a bit of shoulder into the picture, so that we kind of also educate our audience that this also tends to be one of those areas of chronic pain, and sometimes it's very resistant to the usual modalities that we try to treat a patient with. The manual therapy, the electrotherapy, and sometimes we find yet the patient is going on and on about his pain not getting better. I mean, he does have relief when he's in the clinic or post treatment, but the minute he comes back to us for the next session, we find, it's kind of back close to what he came with. So
I
it's
feel, ma'am, over here, if we can teach them to have a control, pain control
exactly. So you have given a
mechanisms.
lot of insights into, about really dealing with the other aspect, which we kind of miss out very often. We do treat the biological part, but the psychosocial, and now, of course, you added the spiritual part, which WHO also has added. I guess we kind of tend to neglect this aspect of pain. So if we kind of, with that small pointers that you gave us, let the patient have a pain diary, let him write about his experiences with pain and how he is coping with pain, whether we can kind of encourage the patient to do some, a transcendental meditation, or a, kind of a heartfulness, or, a mindfulness kind of a session, wherein some bit of a spiritual part can
Spiritual
also,
component.
spiritual component can help, and it need not be religious. Spiritual would mean even just kind of sitting and
Yes.
meditating, and letting meditation, or rather calming your inner self, to kind of help cope with pain better. I guess ANS has a lot of role that we do not tackle. So the autonomic
Yes.
nervous system plays a big role in
Big.
how we project. pain. And I guess through ma'am's talk today, we have been able to touch that aspect also. And she has given us
So
a
ma'am, in future, your CRPS patient should be sent for some meditation. We can ask
exactly.
them. So
Why not?
prescribing them a meditation or a relaxation technique to a CRPS patient has a value over here.
Without doubt. I think even, for example, you mentioned your yoga patient, and how she was able to handle or cope with the pain much better when she was doing her meditation. And I guess even changing the way we breathe, having some pranayama, I guess we
Yes,
have a lot of way forward in doing a lot of research also, ma'am, in kind of how we can bring in all these strategies to kind of handle, control, cope, everything with pain. So ma'am has left a big way forward for us, and the potential is kind of endless, where you can treat combinations or take combinations of whatever physiotherapy modalities are out there and combine it with a psychosocial element, and see how things work out better for you. So all in all, ma'am, thank you so much. I guess this talk has been very enlightening, and I'm sure all the listeners are have really, really benefited from this. So, yeah, for the Physio TV viewers, we will surely, I think, call in Tejashree ma'am again for another enlightening talk in the near future, or surely in the future, whenever ma'am is kind of free and ready.
sure.
And till then, I guess we will kind of sign off for today. I thank ma'am from the entire team of Physio TV team, and we look forward to many such enlightening talks in the future, ma'am. Thank you so
And
much.
I thank Sona madam and team Sancheti for giving me this opportunity, because I myself have started this now. I'm asking them to write a pain reflection and pain diaries. So
Wow.
let them write in whichever language it is possible for them, and then
Okay.
find out the keywords from that.
Hmm. That's very, I think this is opening avenues for understanding our patients and the pain that they experience a little better. Because whatever information we have is usually from the Western world. So I guess, ma'am, you have kind of opened the doors for a bright new research and a bright new way forward. And we look forward to seeing what you found with all that. So we'll kind of call you again even for that, but even for
Sure.
more such talks in the future. So thanks from the entire Physio TV team. Thank you
Thank you,
so
madam.
much.